I'm Laura Bonnell, and this is the Living with Cystic Fibrosis podcast coming to you from Detroit. Please subscribe and even rate and comment on our podcasts when it moves you. I learn something new with every podcast, and I'm always inspired by the people that are showcased here. We don't give medical advice. You need to connect with your doctor for that. I hope that this Living with Cystic Fibrosis podcast educates you and sparks some volunteering or advocacy. The CF community needs people like you. Thanks to our sponsors, Viatris and Vertex, for their support. So the Partnership to Improve Patient Care, or PIPC, that is where Sara Tregel van Gertruden is the executive director. Sara joined PIPC in January of 2011 and serves as the partner at the firm Tom Rum Partners. Her work is focused on policies to advance a patient-centered health system, from patient engagement and research to driving outcomes that matter to patients in healthcare payment and delivery. Sara is a healthcare and welfare policy expert with over 25 years of experience, beginning her career on Capitol Hill, working for a former senator there, and later as an attorney at the law firm Patton Boggs. Thayer Roberts joined PIPC as the deputy director in March of 2019. She works with PIPC's diverse membership of patients, healthcare providers, researchers, and other groups to ensure the patient centricity is the center of our nation's healthcare system. Thayer has expertise in healthcare value assessments and their implications on patients and people with disabilities, and continues to engage in this topic both at the federal and the state level. Well, thank you to, honestly, the coolest, smartest women that I know. Thank you so much for coming on this podcast. We have a lot of great things to talk about.
Absolutely. Thank you for having us, Laura. This is great.
And first of all, why don't you tell us about what PIPC does, and then about your chair?
I'm happy to start, and then there you can fill in. But so Partnership to Improve Patient Care is a coalition that came together. If you think back to 2008, 2009, when comparative effectiveness research was a big hot topic on Capitol Hill, there was a lot of controversy about whether and how government should be funding that kind of research. And it was an interesting dynamic, which is, I think it's interesting because it's still happening today, right? Where on the far left, they really wanted an entity that did not just clinical effectiveness research, but cost effectiveness research, and to use that information in making coverage decisions in Medicare. And then if you looked on sort of the far right, there was a lot of concern that an entity doing comparative effectiveness research would limit doctors in terms of the decisions and their prescribing practices based on what would be paid for. And there was just a lot of concern about spending that kind of money. So when PIPC was created, it was really around this idea that we needed to bring both sides together to come up with a way to fund this kind of research, which patients really wanted, comparative effectiveness research to improve their decisions. But they did not want that information used against them in the context of what would be paid for, what would be covered, because we all know that even though treatment A might work better on, say, 60% of people, there's always people too that treatment B might work better for just because of their personal characteristics, genetics, et cetera. That's where PIPC came in, right? We created this entity called the Patient-Centered Outcomes Research Institute. Congress got behind it. PIPC got behind it. A lot of organizations in town got behind it. And that was really driven by our chair, too, Tony Coelho, who recognized this challenge. And Tony is, well experienced in bringing people together. Tony is the person who, when he was a congressman from California, led the drafting and was the original author of the Americans with Disabilities Act. When that passed Congress, he continued to be a disability rights activist. He also is a person with epilepsy. So that has given him, just from his own childhood and adult experiences, a lot of insight about the kind of discrimination that people with disabilities experience. And so he really brought to this effort a really strong equity lens, particularly for just people with disabilities, and really wanted to make sure that people with disabilities were getting the care that they need and want. So anyway, so that's a little bit about Tony, just in terms of background and why this was really personal for him.
And how wonderful and amazing it is when we think of the American with Disabilities Act now, how important that is, that he started that. How long has that been? Because I don't remember a time without.
And it's really surprising that it has only been a little bit over 30 years. It's 34 years. Is that right, Sarah?
1990, yeah.
It is astounding that going back before 1990, a time that, we can all remember, that was not the law of the land.
And so lucky that it was already in place when my kids were born. I mean, and when all of our kids were born, actually. Their years are way younger than my kid. But,
I wish they'd catch up to yours, Laura, but yes, they are.
You have babies. I have 27 and 29-year-olds. But do you feel coming into this job and coming into PIPC and working with Sara, and you two are quite a team together that I love to work with, because you always have a wealth of information and answers or direction, or you can tell me where to go to get the information.
Thank you. I think that Sara and I both strive to be resources for all of this information, because it is this sort of landscape of cost and clinical effectiveness and value assessment gets really wonky, gets really technical, and becomes very opaque, because a lot of this is happening behind the closed doors of payer decision-making, P&T committees, now these prescription drug affordability boards in several states. And it can be really hard to follow these processes. And if you are a patient advocate or a patient or caregiver whose primary concern is providing direct patient service, taking care of yourself, taking care of your child, it's inconceivable that you would be able to stay up to date on all of these kind of technical behind closed door nuances and papers and comment opportunities and all of that. And it is very challenging. So to the extent that we're able, we do try to break that down and make sure people are aware of what's happening and how they can engage, and where you can find reliable and credible resources, and, all of those necessary things.
And one thing that I love to get is your newsletter. I feel like when I get that, I can look at information on my own time. It's written so that I can understand it. And I really encourage everyone else to find that information, because I do feel like I should wake up 2 hours earlier and read all. I think we kind of all should be doing that, getting all that information before your day gets started. But the newsletter I get in my email, but it's also on your website.
Yeah. And, the newsletter is something that's evolved over time, but we really, from the beginning wanted to make sure that, it was keeping people informed about what kind of comparative effectiveness research was going on out there. It's really evolved now, where a lot of the kind of articles about what's going on in this world of value assessment doesn't necessarily get picked up in a lot of other folks' newsletters. And so our hope is that this provides sort of a niche resource for people who care about these issues and want to engage on them.
I think it does. And I also think what's really been an eye-opener for me is when I held my education day last May, and so many of the cystic fibrosis families, because that's obviously my rare disease, but so many of the cystic fibrosis families are so busy in their lives making, getting their medications for their kids. They don't have time to think about legislation. So when I was talking about the Prescription Drug Affordability Board or the Rare Disease Advisory Council, QALY, and all these things, they didn't know anything about it. They were shocked, and then they were like, oh my gosh, what can we do? And as recently as a couple of days ago, I was at the National Organization for Rare Disorders Summit, and a group of us on one day, the 29 states, hopefully Michigan's the 30th, but for that Rare Disease Advisory Council, even those members, when we were talking about the Prescription Drug Affordability Board, were not familiar with this. They were like, what's it about? So if you can explain what the PDAB is and what's scary about it.
So prescription drug affordability boards are an idea that came out of an entity called the National Association for State Health Policy. It's often referred to as NASHP. And even going back before NASHP, right, we've always had concerns about the Institute for Clinical and Economic Review, because that entity uses these measures called QALYs, and now a measure called the Equal Value Life Year Gained, which you'll hear it referenced as the EVLYG. ICER does these cost value assessments using those measures, which are of great concern to the patient and disability communities due to their implications for discrimination and devaluing disabled lives in those measures of what's quote unquote, cost effective. And NASHP is very aligned with the use of ICER studies. And so when you look at a lot of the template legislation they have around drug pricing, it sort of embraces the concepts of using those types of value assessments. So in that, when they sent template legislation to the states, a lot of states picked up on it and then have moved to pass laws creating these prescription drug affordability boards that have potential to use those types of measures in terms of how they value drugs and then what potential upper payment limits they set on drugs. So our response to this has always been to try to create a bar on the use of QALYs and similar measures in any legislation that's moving in the states to create these boards. With limited success, I'll admit. There are some states that have had some narrow QALY bands included in their bills, but then later on we find out that the boards are sort of finding loopholes around them to still use, like whether it's to still use the equal value life or gain measure, which in fairness doesn't really make sense when it's not used in conjunction with the QALY, and or to use other types of cost effectiveness measures that are unclear in terms of whether they would be barred under the law. But regardless, we would argue they still need to be looked at in the context of their limitations and trade-offs for providing more value to one thing, less value to another. EVLYG, for instance, provides more value to drugs that extend life, but does not account for quality of life improvement. So if a product or a treatment doesn't have an impact on life extension, but it makes your life better, that would not necessarily be given value under the EVLYG. And so that's why, and you have to look at all of these measures sort of in those contexts of trade-offs and limitations. And that's been a real struggle with the prescription drug affordability boards, because they're really looking for some sort of like easy benchmark. And there just really aren't any easy benchmarks in the cost effectiveness world.
And what you just said, I'm sure to people sounds like you're speaking a different language, because I think...
So sorry.
But truly, because we've been in it for so long, we get it. But there is a lot to learn. And I know that I don't even think our governor really understands what the PDAB is completely. And it's just because she isn't immersed in it. And I don't think all of our lawmakers do. And I know our rare disease community doesn't, because lawmakers haven't presented it enough. And I feel like even my nonprofit and other nonprofits, we need to hold webinars, and we probably need to hold in-person gatherings too, to say, hey, if you're not getting the information, here's what it means, because it can get confusing. And I think even the people at the conference I was recently at, who maybe should have known just because we're in that field, they don't even know. So I'm just saying nobody should feel bad. There's so much to learn and understand. And, this Rare Disease Advisory Council in Michigan that we're working on has taken 6 years, and it still isn't passed by the Senate. We're waiting for the full Senate. But yet the Prescription Drug Affordability Board, or PDAB, was rushed through the Senate within a week. Mm-hmm. And then I ran to the House members and was like, wait, does anyone here understand what the PDAB is? And they didn't. So they all agreed that they had to slow this process down because they didn't know anything about it. They weren't familiar enough.
You're really hitting the nail on the head of the challenge here, Laura, as this is such a deeply complicated topic. You're right. No one should feel bad about not being in like the minutia of this. It is overwhelming. It is wonky. It is technical. It's what Sara and I spend our days and nights doing, and I still find it confusing sometimes. So it's hard. And to your point about people not fully understanding this, I think that's really the crux of the problem. Like, we're seeing these bills be rushed through in a lot of states because they seem like a silver bullet, right? It seems to lawmakers like this is just going to be the solution to healthcare costs, and they can do this and it'll be done and easy. And the reality is there's not a silver bullet. It's really, really complicated. And I think what we're seeing in states that have passed them is that they're realizing that, right? Oregon actually put a pause on its 2024 assessments, and they acknowledged that they need to develop a better understanding of what affordability means, both to the states and to the state and to patients. And that's pretty baseline, right? If the goal is to provide more affordable healthcare, you have to know what affordability means. You have to understand how the healthcare is paid for. And, I actually think it's astounding, but great that Oregon admitted that, because it is a helpful tool for us to say, this isn't as easy as you think it is. And it's important that you stop and determine what your goal is and how you're going to do it before you endeavor upon this huge policy, right? But I also think we're seeing this in states beyond Oregon. In many of the PDAB meetings that I have listened in on, it's very clear that the board lacks understanding of certain aspects of the healthcare system and how things are paid for. And the patient advocates on the call have more information on some of this, like what their out-of-pocket costs are, what copay assistance is, how much they're actually paying for their drugs. It's clear that many of these board members don't have a full understanding of that. So it's hard to make decisions in a vacuum if you're not seeing the full picture and if you're not understanding the whole ecosystem of how patients are accessing their treatments. So I do think education is really important in that realm. And as other states are starting to consider these forward, I think it's imperative that patients are in talking to their legislators, explaining some of the issues that have happened in other states and explaining, what their priorities are as patients and what would help them getting the care that they need. Because in most cases, it's not a PDAB.
I always go back to Colorado, where the process was huge learning curve for their board. And it was honestly crazy.
Mm-hmm.
A little bit of crazy, I would say. It was the way they treated people who were testifying was not professional. And it was just, they've learned a lot. But I also always bring up the fact that Senator Barbara Kirkmeyer of Colorado even stated after this process, she didn't support it. Once she learned everything about it, and then she had all these other lawmakers who agreed with her, signed their name to a letter. So there is such a huge learning curve. And I just wonder, Sara and Thayer, if this is a good, really short synopsis of it. So this is a board that is deciding whether your medication will be paid for. And then the quality adjusted life year is a discriminatory measure that's used in this process, right? And the deciding whether it's worth it in someone's eyes, whether or not your disease gets a medication. Is that a correct, short synopsis, or if you need to elaborate more?
So essentially, what these boards are doing is they'll assess the affordability, whether patients can afford it, right? And how they do that is controversial, because what makes a drug affordable or not affordable is often up to the payer, as opposed to so a payer could put a drug on a certain tier, right, or require a certain copay, and that drives a lot of the affordability challenges that patients are dealing with. That and a whole host of other issues: transportation, dosing, et cetera, et cetera, et cetera. In Colorado, for instance, you'll remember Trikafta was one of the drugs that they considered, and they did not deem it unaffordable based on the input from patients who were like, we're getting our medication and please don't do something that threatens us getting our medication, right?
Right.
Now, the boards are going to set a number payment limit so the drug does get paid for. That's like, but it's at the same time, if the payment rate is low, what happens then is that because of the way that pharmacy benefit managers and payers work, it may or may not be worth it to them to put it in a preferred tier. So there's a lot of potential implications that patients may face in terms of utilization management strategies. And there is the question of whether the drug, like with Trikafta, whether that drug would be even made available in that state if a payment rate was set too low. So I think that what the PDABs are struggling with is this now, I think, recognition that if you're looking at how much you value something based on these qualities and similar measures, and you set a payment rate that's low because you've decided that patient can afford it as is, are you helping? And yes, you may drive state budgets in terms of their costs down, but you may not be actually saving patients money if now their drugs are not preferred, if now their drugs are not, so now they're basically, if patients are potentially now paying out of pocket more because of not being on a preferred tier or having to pay out of pocket because it's just not covered. And so that's where these laws have gotten really confusing, and nobody has really good answers for how to address that because the laws don't address these challenges in terms of patient access.
And the point is that not me, but my children, the patients, wouldn't see the savings. It seems like.
Right.
It's not about I think it's billed as it's going to save you all money, but that's not the actual fact of what's happening. And it could, like you were saying, Sarah, it could impact research and development with pharma and that aspect as well.
It could. And even, one step before that, it could actually limit access now to drugs that are, available, approved. To Sarah's point, there are instances where, depending upon how the price is set, that it may not be accessible in the state for, numerous reasons. It could be that the manufacturer stops selling it to the state, or it could be that it's too inexpensive for hospitals to stock to infuse because their reimbursement becomes too low, right? So if you're talking about a Part B drug, there's an instance where it's not necessarily, a manufacturer decision. It may be a hospital decision or provider decision because of the way the reimbursement works not to stock that treatment.
Yeah, I'm glad you're bringing up pharmacies there because that's where if you're watching the news on those PDABs and Medicare negotiation, there's been a lot of news recently about concerns about whether pharmacies would be able to afford to stock these drugs.
Yeah, and I think that there can be some confusion there when people are talking about this, because when we think of prescriptions, often as kind of lay people, your rare disease patients probably are more in the weeds on this, but when your kind of average lay person is thinking of prescriptions, they're thinking of driving to their local CVS, their Walgreens, picking something up over the counter, right? So that's a thing. Your prescription drug benefit where you just, pay your copay, take it home. But there are also medications that you have to get in the hospital, and the hospital pharmacy has to decide to stock them. And a lot of those decisions are based on how they're reimbursed for those medications. So setting the price too low can have access implications.
Isn't there a fact where there's a wait on when they're reimbursed? So it could be a while before that pharmacy is reimbursed and they're waiting.
Mm-hmm. And that's just kind of the standard CMS process. And part of that is how ASP is calculated. And then we're getting into all sorts of other wonky topics that we could probably use 12 podcasts to discuss. But you're always dealing with this lag time, right? So if you're dealing with lower reimbursements in addition to this lag time, it just is an added challenge.
And what's the most important thing for people to know who are in fact dealing with getting their treatments ready for their kids, running around with little kids, they're super busy? What is the best information they should know about the Prescription Drug Affordability Board, and what can they do even if it's a small act?
So I would say there are two different elements here. One is your state considering a prescription drug affordability board? And two is if your state already has a prescription drug affordability board. These things can be challenging to keep up on. I would suggest a good website that kind of tracks all these things is patientaccessproject.org. If you're just looking to see, as we enter legislative session, is my state considering a PDAB? That's a good place to go to find out. Sign up for the PIPC update too. That's another good place to go to find out. But if your state is considering a PDAB, I would say make it a point to talk to your legislator. If you can find the time to go in and have a meeting with your rep and your senator, do it. If you can't, send a letter. Engage with your local rare disease community. If you're in Michigan, Laura, I would encourage folks to engage with you. You're keeping on top of this. Every kind of state and region has a few groups that are doing a really good job staying on top of these issues. Because I think it's important for legislators to hear from patients that they don't support this and this isn't going to solve the problems that they're worried about, and to hear the things that they are worried about, right? It's a good opportunity for you to talk to your legislator about, this is actually potentially harmful, but here are 3 other things that really concern me, and here are things I'd suggest you focus on instead, right? So a meeting like that could serve multiple functions. If you can't get in for a meeting, send a letter. Just make it known that there is concern. Your legislators work for you, and it's important that they understand the whole dynamic there. If there is already a PDAB in your state, it can be really hard to stay on top of the activities that they're doing. The websites are tough. The meetings are oftentimes long in the middle of the day. So I understand the challenges there, but if you can, participate, give comments at public meetings, submit testimony. Again, Sara and I are always happy to be resources to, share with the patient community when we know these things are available. The website, patientaccessproject.org that I mentioned, does a really good job of updating those comment opportunities. So I would just stay on top of it and participate where you're able.
The lawmakers are receptive. 99% of them will either admit to not knowing or, hey, help me get more information, and are approachable. And I think it's really important to talk to them because they want to know more, or they, like I've said to them, how many programs have you offered where you're talking about this PDAB? 0 is what they say. So okay, so we all have to work on education is a huge thing, I believe. But those are good suggestions because people do want to help in the rare community. They want to help at a level they can help at, whether it's a letter or a phone call. Maybe they can't go in to the state capitol and do something, but at a smaller level, they can get involved.
And each state, I feel like, where these issues are coming up, creating coalitions can be helpful, right? Because I understand if you're a patient or a caregiver or a parent, it can be really tough to find the bandwidth and the time to do this. But you can add your voice to a coalition. You can add your voice to a letter. You can add your voice to what we know and we do in Michigan is in large part, Laura, because you keep us informed, right? And we learn from you when things are moving and where there's a need to engage and get involved. Tony has submitted testimony, those kinds of things because it's important to be engaged. But we know this from, the state-based advocates, right? And they're really leading the charge. And I do think that ultimately state legislatures want to hear from their local constituents, right? They really want to hear from people in the state. And that's why it's imperative for people in the state to be involved and engaged and at a minimum asking them questions, right? What impact will this have on me? How are you going to protect me from utilization management strategies? How are you going to protect me from an impact on access to care that emanates from this process? And so, that's just... And so I think when you ask a lot of questions and, when you ask, say, hey, are you going to bar QALYs and similar measures, right? I mean, that's a question that we always ask. Then they go, wait a minute, what's a QALY, right? And now you've got a conversation.
Yes. And what is kind of your biggest fear? I know we've talked about this, but I think about my girls and Sara, your boys are around the same age, but they're going to have to learn all this when they have kids. Maybe. I just think we have to get this all fixed before I die, so everything is set up for my kid. Of course, that's not going to happen because it's an ongoing living.
I don't want to think about you dying anytime soon, Laura.
I mean, I'm just like 120 is my goal,
Yes.
you know. But still, even if I make it to 120 years old, like it's a never-ending process. Realistically, that's ridiculous what I'm saying. But you know, the thought is we have to like get some things in place so that our kids don't have so much to struggle with, right?
Look, I mean, this is what Congress is battling right now. I mean, and on the federal level, right? I mean, there's a lot of bills and a lot of legislation that has been sort of sitting there waiting for Congress to do something. And the first thing that comes to mind when we have this conversation is PBM reform, right? I mean, it's
pharmacy benefit managers.
So pharmacy benefit managers, which are the entities that are driving a lot of these issues around affordability and making sure that that whatever savings they may be getting in terms of how the discounts and the rebates that they get on drugs, they're not necessarily passed down to the consumer, right? And you're seeing a lot of these utilization management strategies that emanate from that, right? And Congress is grappling with this right now. We're not sure what's going to happen. You know, fingers crossed. We all hope that Congress does something in November after the elections around these issues, but that's going to have a big impact here as well, I feel like, right? If some PBM reform happens, I think that's helpful, but there's a long way to go. And I know a lot of these PBM kind of conversations are happening in various states as well. So,
and can you talk about what the concern over the pharmacy benefit managers are, just so people understand a little bit?
Yeah, I mean, so a pharmacy benefit manager, I mean, then this is where there's a tremendous amount of lack of transparency, right? I mean, from PIPC's standpoint, we've always come at this from the perspective of how these types of value assessments, qualities, and similar measures may be used and how payers value things, therefore how they negotiate. And then there's the spin-off concern around, you know, the manufacturer has a list price, but PBMs are going to get it for a lot less. All we see is the list price, right? That's not necessarily the price, right? So, and then the questions become around how much of the savings are then being passed to a patient or the employer even that's paying for the plan. And the PBM is basically saying, well, here's your form. They're giving you the formulary, right? Whether your drug is on a preferred tier. If it's on a preferred tier, your copay is less. If it's not on a preferred tier, your copay is more. And this is where it gets muddled because from PIPC's perspective, right, I think I go back to the very beginning of this conversation. When we were creating PCORI, right, when we were working with Congress on the Patient-Centered Outcomes Research Institute, and you had these two sides, we're still seeing that play out today, right? Are we going to allow what works best for the averages to then drive what people get access to and at what cost, right? If we're preferring things instead of allowing patients who may not be average to get what they need at a preferred cost. And, you know, not everybody is going to fall into the averages. And that is, I think, a problem that continues today. Payers are trying to say every patient needs to go through step therapy or prior authorization because we want to drive patients toward this product or that product because that's where we're getting our deals, you know, and instead of allowing patients to access what is going to work best for them. And, you know, ultimately that's where we are. We want patients to be able to access that which a doctor and the patient say, this is what's going to work best for you based on your characteristics and what we know about you. And we're just not living in that world right now. And it's frustrating because when the Affordable Care Act passed, right, we not only had PCORI, but we also had provisions around shared decision-making, which has not been implemented. I mean, the idea was we wanted to give, you know, I think the way that the shared decision-making statute was drafted was it was called preference-sensitive care, right? Well, I don't think a lot of us would say that our system right now is delivering preference-sensitive care, right? When we're told we have to fail on one thing before we can get to the thing that we need and want and what works. That's not
Right.
preference-sensitive care.
And so hard for the rare communities, as you are well aware, which is 200,000 or less people that are impacted by a disease. Because if you only have one drug that's good or works differently for that community, it can be a huge barrier to that drug.
Yeah. And I mean, the rare community has its own kind of host of challenges that exist, beyond your sort of access to therapies for more populous diseases. You see a lot of challenges with drugs that are approved via the accelerated approval pathway, which many rare disease drugs need to be, because you need to be able to rely on a surrogate endpoint instead of a placebo-controlled clinical trial for rare disease drugs. And then you see payers referring to them as experimental and not covering them, and you need to go through this, lengthy appeals process. And as we know, days, weeks, months matter when you're struggling with a rare disease, when your child is dealing with a rare disease. So there are a host of challenges to be solved, to your earlier point, Laura, and, we're really just kind of chipping at the tip of the iceberg on them.
Well, and I just want to make plug too for one of the bills that we're pushing really hard for right now is HR 485, which is the Protecting Healthcare for All Patients Act, which is a bill that was introduced by Kathy McMorris-Rogers, who's chair of the Energy and Commerce Committee in the House, and she has a child with a disability, so it's a really big personal priority for her. And all that bill does is extend the protections that exist in Medicare that were passed in the Affordable Care Act against the use of qualities and similar measures to make reimbursement and coverage decisions. It basically takes those provisions and extends them to other programs. So think Medicaid and state-based issues. I mean, already we have regulations under Section 504 of the Rehab Act that bar qualities and similar measures. But we are really hopeful to see those codified in statute, which is what HR 485 does. And so, I think that also has a really big impact on these payers, because to the extent that they're using discriminatory value assessments currently to make decisions that impact how you get care, whether it's denied or whether it's managed through utilization management strategies, that bill would help to make sure that, we're hoping it forces people's hands to kind of get under the hood of how decisions are getting made, because it's almost impossible for us to even say, oh, we know you, payer, are using XYZ value assessment to make this decision, and you can't do that because we can't see it. We don't know what's going into these equations behind the scenes, and that's a problem.
Right. It's so important because the majority of people, they just don't know where to find this information. I mean, I've just told people, like, the 504, it is so, somebody had a question about what was covered in public schools and, didn't even know where to go to. So it's really important that you can help people figure out even just where to go to get that information too is really important. And all of these acronyms and everything I'm putting in show notes. So if people are confused, they can look at them because there are so many. It really is a different language. And I think too, it's really important that we hold everybody accountable. It's not like finger pointing at one group, because everybody has to work together, and it's education and all of that. Is there anything that you're most concerned about, a legislation or an issue that you think is the hottest thing that we all have to focus on right now?
There are a lot. I would echo what Sara said about ensuring that this broader QualiVan bill, HR 485, does get across the finish line. Codifying those protections in statute would be seminally important, and that would impact pretty much everything we've just talked about today. So putting those protections in place would be a great backstop for us to then deal with all of the rest of this.
That is great. And what about, I know there's so much talk and work in the Inflation Reduction Act.
Laura, we might need a second podcast on that alone.
Okay. Well, we can do that.
There is so much, and a lot of the issues are really similar to what we just talked about with the PDABs. So There's a lot to unpack there, and advocates do need to understand what's happening and make sure that their voices are heard in that discussion too. And, I was kind of kidding, but it may be worth a whole other discussion for us to unpack.
Well, I think you're right. I think it's taking the information in segments and digesting what you hear, and kind of like a 101 on this and a 101 on that, just learning the basics of everything, because it is so much to take in for people when they're just learning about it.
I think what's interesting too is that when the Inflation Reduction Act was being passed, I don't think that everything was just unknown. People didn't know what this was going to mean. We know a lot more now, and I think a lot of the state-based advocates understand the threat, and they understand the potential implications better because of their engagement in PDAB work. As this evolves at the federal level with Medicare negotiation, my hope is that it drives more patients to be engaged in that process, because in the first round, patient engagement was not great. And frankly, the agency did not support a very robust patient engagement process. So we hope that it's better next time, and that going forward it improves. And that hopefully will provide more of an opening, and these state-based advocates who now know the questions to ask, right? And they know what the concerns are. They can bring those concerns into the federal process too.
I think it's great advice, and I think that everybody should, check out the PIPC website and patientaccessproject.org.
Yes.
Correct?
Yes.
So
it's a great resource.
And as we wrap up, what are your thoughts as we close out this first discussion, which might be somebody's the first time that they hear about all of these different issues?
I would just say do your best to get educated on them. It seems confusing, but it's helpful to know what's going on. It does have real impact. Please use the PIPC resources. Sara and I are readily available to the patient and disability communities. If you have questions, we're easy to reach. You can find both of our emails on the PIPC website, pipcpatients.org. So just, get educated and don't hesitate to reach out.
Ditto. We're very excited, and thank you, Laura. I mean, it really, my advice is to become like Laura. You're such a great advocate, and you've done a tremendous job of, your work to create a rare disease advisory council in Michigan, and to stay engaged on these issues and to raise these issues and to educate on these issues is just, it's just seminal. It has to happen, and it has to happen across the country.
Well, thank you both so much. You are the best wealth of information at our fingertips. So I really love it. And everything is in show notes so people can find you. So thank you both.
Thank you, Laura.
Thank you.
The original music in this podcast is performed by Kevin Allen,
It's not complicated.
who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Vertex Pharmaceutical, The Science of Possibility, and Viatris. It was produced by Jag and Detroit Podcasts. Follow our show in Apple Podcasts, Spotify, or wherever you're listening right now.